Dr. Mangwani will walk us through the thoughts on how to address and in what ways to attack the acute calcaneal fracture. Dr. Mangwani.
My name is Jitendra Mangwani. I'm a consultant in University Hospitals of Leicester. And we're going to talk about acute calcaneal fractures. As I said, I'm joined by three of my esteemed colleagues on the panel, Roland, Lucky, and Alex. So we're going to get cracking with a bit of a background about calcaneal fractures. Calcaneal fractures are most common tarsal bone to break, about 2% of all fractures, and they are usually as a result of high velocity trauma, and the outcomes of these fractures traditionally have been pretty bad, and we all know that. Next one, please. And the type of fractures are extra-articular or intra-articular. Mostly 3/4 tend to be intra-articular fractures. Next one, please. So in the extra-articular, a bit of a take-home message here for the ones who deal with this type of trauma. This extra-articular tuberosity avulsion is the one to look out for. This needs emergency attention because of the soft tissue being threatened. Next one, please. So as you can see, with this type of injury, soft tissues are threatened, and it needs really sort of looking after it quickly, putting the patient in plant flexion and getting into emergency reduction and fixation. Next one, please. And here you can see you can use a variety of fixation methods, and I'm sure different people use different methods, and we'll come to that in a second. But the key is to take the pressure off the soft tissues and avoid a potential disastrous situation of a full thickness defect in the soft tissue. Next one, please. So with the intra-articular ones, the goal of treatment from a surgeon's point of view is to restore the heel width, get the anatomy right, get the bolus angle sorted, and start early rehab. From patient's point of view, they want a pain-free plantigrade foot that they can put in a shoe and they can walk on it. And we all know, next one, please, that the outcome of these injuries is sometimes not as good as we want to see. And here's an example of reduction tunnel fixation of an intra-articular fracture, which has led to the soft tissues breaking down and a non-union in the end. Next one, please. So there's plenty published out there as well, but if you look at it, if a patient ends up with a situation like this, then that's not a happy situation to salvage. Next one, please. And as I said, published literature is almost 5,000 papers in PubMed itself. But next one, please. Have we really answered all the questions? Because the optimum management of this condition is still controversial. Does anatomical reduction lead to good outcome? We'll talk about that. And complications are not infrequent, and there are newer techniques on the horizon, which we'll talk about in a second. Next one, please. So the step off is leading to increased joint forces, and surface redistribution of the joint forces is changed as a result of that. And some of the clinical trials have also hinted at that, but does it really matter? So we'll talk about that. Next one, please. So factors affecting outcome, there's plenty of those. I'm not going to go through each one of those, but I think key is to look at patient's factors, host factors, comorbidities. What approach are we going to use? Is there a learning curve for the surgeon for this particular type of complex injury to treat? And there have been randomized controlled trials on this particular topic, a particular injury. And I'm just going to go through quickly three of those randomized trials, and then we can talk about some cases relating to this injury and leading to some discussion further. Thank you. Next one, please. Yeah. So the Canadian one was the first one, 2002, Buckley trial. And this was, next one, please. This was done in 4 trauma centers, and patients were randomized to open reduction or non-operative treatment. All fractures were classified, and there were 512 patients treated, of which they had 309 for the final outcome. And the outcome measures were SF36 and VAS. Next one, please. So the conclusion in that trial was there was no difference between the 2 arms of operative and non-operative, but if one took the workers' compensation group away, then there was a favorable outcome for the RF. Women were managed operatively did better, and the non-operative treatment led to 5.5 times higher chance of subtalar fusion. Next one, please. And the next one after that was the Per-Henrik one, and that came out in 2014, if I remember correctly. And this trial again had non-operative versus operative management, and it had a longer follow-up, 8 to 12-year follow-up. And there was a bit of a trend towards better score in ORIF in patients who were followed up to 8, 12 years. And also with ORIF, there was 41% risk reduction for subtalar fusion, but there was much higher complication in that group. Next one, please. So the most controversial to date is the UK heel fracture trial. It was 2014 again, and this was essentially comparing open reduction tunnel fixation versus non-operative treatment. Next one, please. So they screened 2,006 patients, and 502 were potentially eligible. This was conducted in 22 hospitals across the UK. And if we look at it, 27 surgeons treated these fractures, making an average of 2 per sort of per surgeon caseload for open reduction tunnel fixation. In the end, 152 patients were included. One of the exclusion criteria for this was if the injury was severe enough to require surgery, those patients were excluded. The outcome measures were Kerr-Atkins, SF36, EQ5D, and they were fastened. The follow-up was for 2 years. Next, please. There was also an editorial in the BMJ raising a bit of a concern about whether these fractures ever need fixing, and I think there was a lot of criticism of a reporting of this particular trial not being so sound. Next one, please. So, Chris Pierce and James Calder did this annotation in the BJJ on the back of this, and there was a criticism, as I said. Next one, please. And they highlighted some of the points about low volume per surgeon, operations not done by foot and ankle specialists, potentially leading to selection bias because of the type of injuries they treated, and also more complications and less favorable outcome, because if you're not doing many, then you won't be good at it. And the follow-up was only for 2 years in that trial. Next one, please. Subsequently, they have presented a 5-year follow-up, and that's not shown any difference either. Next one, please. Okay, so this then sets up the stage for Roland to talk about a case and mainly going through open reduction tunnel fixation as the initial treatment for fixing. Thank you.
Thanks, Jit. So I hope we can present a range of different cases and techniques to try and illustrate to the audience the different options available. As I mentioned, I once worked for Professor Atkins, and I thought therefore it would be useful to show a conventional open reduction internal fixation case. So the case history here, this patient was a 39-year-old gentleman. He was actually a local family doctor, general practitioner, and he'd been enjoying himself at the Notting Hill Carnival, which is a big street festival in North London, and was dancing on a podium with some friends, and unfortunately got sort of knocked off this podium and fell from a sort of 8 to 10 foot platform, landing on the tarmac. He had an entirely isolated injury to his left calcaneum, and this gentleman was an extremely fit, athletic guy. He competed in triathlon and sort of long distance running events, and was very, very keen to get back to his sports. These are the initial radiographs when he came in, and what they in effect show is a loss of the bolus angle, a loss of height from the posterior facet of the calcaneum, and a depressed posterior facet fragment, but not a really highly comminuted fracture. And when we look through the CT scan, we can see a relatively large constant fragment, so a relatively large sustentaculum fracture, which is favorable because it allows us to fix the depressed fragment to a reasonably stable fragment. And there was really one large articular fragment. So this is a more simple fracture pattern. And so I discussed the options with this gentleman, explained the options of open versus MIS, but these were the reasons that we elected to go for an open surgery. The patient himself was wanting the best possible anatomical reduction. He was really keen to try and get back to sports. And although I explained some debate around whether a really precise anatomic reduction does correlate to less arthritis and a better functional recovery, we both agreed that that would be the aim of treatment, and I felt that open surgery would give me the best access to the subtalar joint and the main articular fragments, and therefore the best chance of giving him a really anatomic reduction. He was also extremely fit, compliant. He was a non-smoker. I think overall I would call this kind of injury, this is a moderate energy calcaneal fracture. It's not a really high energy polytrauma, and consequently his swelling and the soft tissue envelope was actually in reasonably good shape as well. So those were the factors that led me to offer him extended lateral open approach. And this is the approach. It was developed, as I mentioned previously, based on this arterial supply to the skin on the lateral border of the foot. So Professor Atkins established that this posterior this perineal perforating perineal artery and its posterior branch with a main blood supply to this flap. And in addition, raising this flap raises the sural nerve and all of its branches effectively, and that is good for reducing the risk of neural injury. In terms of technical tips, I pretty much follow the original surgical technique with one or two slight modifications. So I tend to do two long limbs with a sharp corner of not less than 100 degrees, so an open angle there. I start incision on the lateral edge of the tendo Achilles and then go down to the junction of the glabrous and non-glabrous skin. And there is a calcaneal branch of sural nerve which can sometimes cross that lower corner of the wound, and sometimes it has to be sacrificed in order to make the approach. But it has a relatively small functional consequence. I just warn the patients of a little numbness on the heel. I raised the flap full thickness, and the original paper says to take some of the adductor digiti quinti muscle, but I have to say I tend to leave that muscle alone and try not to incise into it to reduce the bleeding and the risk of hematoma under the flap. And then you certainly have to release the inferior perineal retinaculum and its attachments to the perineal tubercle in order to be able to mobilize the perineal tendons. And distally between the perineal tendons and the flap, you sometimes have to create an additional window to access the anterior process of the calcaneum. It's absolutely fine to release the calcaneofibular ligament in order to access subtalar joint. There have been a few studies showing no sign of varus instability of the ankle following this maneuver. And then K-wires as retractors into the fibula and the talar body are really handy. So this is a schematic, and it just shows that you really have to release around this perineal tubercle and the inferior perineal retinaculum to be able to mobilize these peroneal tendons. And then the final bit of this approach would be to release the CFL and the capsule there to access subtalar joint and get a good view across the sinus tarsi and the posterior facet. Atkins' team looked at 150 consecutive cases, so a large series. And I have to say that the complication profile for such a large incision and approach in, quite a multi-injured population was quite good, with relatively low complications. So this was the result that we managed to achieve for this gentleman. We got a pretty accurate restoration of the subtalar joint with restoration of Bowler's angle, relative congruence of the subtalar joint. And I'm not sure if this video will play, but I'm afraid probably not. So there's a little video of this gentleman walking back and forth with good flexibility in his hind foot. And this was taken at around 6 months, and he had just started jogging again. So relatively satisfactory outcome. So really, this is the key reference, the Atkins and Patricia Allen paper. Colleague of Patricia is a colleague of Jit's, and I think the take-home message is that in a healthy non-smoker with no major comorbidities and perhaps an isolated injury, this extended lateral approach does give good access for an anatomical plating. And it is relatively safe with an acceptable complication profile. Thanks very much.
That's great. Thanks, Roland, for sharing that case. Obviously, one of the complications that we see is a wound problem with particularly extensile lateral approach or extended lateral approach. And if we look at the literature, the deep infection rate can reach up to 5 to 6%, 7%, and wound dehiscence is reported at 10 to 14% being one of the worries. And that, next slide, please, has led to the development of further techniques, evolution of techniques, and one of them ranging from obviously sinus tarsi approach to percutaneous approach to arthroscopic percutaneous approach. So we're going to go through one by one, and with illustrative cases. We'll go through the sinus tarsi approach. Next one, please. With the sinus tarsi approach, is it a new approach? The answer is no. If we look back in 1948, Palmer described pretty much what we now do for sinus tarsi, and that's the approach Palmer described. And actually that was in the 80s, 90s, almost sort of abandoned in favor of the extended lateral approach. But with the recent change in the techniques and availability of a variety of metalwork to support it, this has certainly been one of the approaches that's extensively done and studied. So Lucky's going to share a case and talk us through some tips and tricks of sinus tarsi approach. Thank you, Lucky.
Great, thanks, Jit. So like many of us, I think we've all been on a little journey that started, as Roland has beautifully described, with an extended lateral approach. And then, as I guess my practice has evolved, I've become, I hope, much better at doing percutaneous techniques. And that's one of the things I'm going to talk to you about today. So now I haven't done an extended lateral for probably about 10 years now, since I was a resident or registrar. But one of the things I do like to do is sinus tarsi plating. If you flick on to the next, thanks, Roland. So for me, when I'm trying to decide about whether to do something purely percutaneously with just screws or whether to use a sinus tarsi plate, it's very much for me to do with soft tissues and the configuration of the fractures. So this was a 34-year-old gentleman who was a police officer. He was chasing after someone and fell off the edge of a roof, fell about 5 meters or so, and sustained isolated injury to his calcaneus. And actually, Roland, if you go back one for me, please. Sorry. Brilliant. What you can see here, and I guess one of the most important views to look at here is your lateral. You can see that there is some congruity in the posterior facet of your subtalar joint. But you can also see that there's a separate fragment. And sorry, I don't think my line's going to work, but you can see there's an articular surface right in the middle of the picture that's almost vertical. And for me, you often see that it's the lateral side of the subtalar joint that gets punched down like that. It looks like a big fragment to me. The other things I'm looking at are what's your tuberosity like, and you know, we've got a good bit of patent tuberosity here. On your axial, interestingly, the alignment doesn't look terrible on this axial. You can see that it's straightish. There's the usual big constant fragment of your sustentaculum. And if you flick on, Roland, thanks. Yeah, again, this slightly more clearly shows on a plane radiograph that big depressed fragment. And for me, elevating that back up and getting that subtalar joint restored is going to be key to the outcome here. We CT all of these, and so if you move on, Roland, thanks. And again, this just confirms more than anything what you see on the x-rays, which is that the medial side of the subtalar joint looks pretty well reduced. You've got a big tuberosity fragment, but as you come laterally, you see there's this big fragment that's been punched down. Importantly for me as well, I try to look at the anterior process because a lot of my perk fixation techniques are going to anchor either screws or the front parts of a plate in the anterior process. And as we'll see, it's not always patent, but in this case it was. So hopefully if we flick on now, thanks. So I'm also careful to look at lateral wall blowout because that can give you the subfibular impingement. And one of the things about the sinus tarsi approach is that it does still give you access to the lateral wall of the calcaneus. So you can still do things to remove any lateral wall blowout or, you know, get a bit of compression with your plate. But again, something I look at on the coronal views. And if we go on, we should get to some II pictures. So this is a Shantz pin in the tuberosity, and it's on a T-handle. In this case, we had quite a large tuberosity to work with, but normally I go a little bit more plantar, maybe a little bit more posterior. And really what I'm trying to do here is pull the tuberosity out, so restore your calcaneal length. I then pull the tuberosity down to try and change that height as well and improve that. And then the other thing is rotation of the wrist. So you're rotating sort of your wrist internally to try and get the tuberosity out of varus. What that maneuver does is allow you a bit of space to then lift up that depressed fragment. And the middle picture on the top row, you can see that what we've done is we've managed to elevate it. You can see the clear space underneath that fragment, which is where all the bone was squashed. And then we just use a small KY just to hold it in place. And then as we go on, we've applied a sinus tarsi plate, which sits quite subchondral there. You can see the screws will be raft screws going across the posterior facet, and then added a couple of screws to connect the tuberosity to the anterior process. And overall, I think we've done a pretty good job of restoring the joint there. You've always got to be hypercritical of everything that you do. I think you can see the screws going into the sustentaculum could have been longer. Although my main objective was to restore that depressed fragment on the lateral side. And you can see the heel does look like it's still in a bit of varus there. So always, you know, the other thing I'd advocate is looking critically at your x-rays. Again, if you go on, I think we've got a 6-month x-ray, which shows that, you know, the reduction was maintained. He's got back to active duties and he's not had to have any metal work removed yet, which is great. So what I would say about the sinus tarsi approach and the plating is that we know that from the studies that it gives you at least equivalence in terms of radiographic and clinical outcomes. But what we do also know is that it reduces your incidence of wound complications compared to the extended lateral approach. And I think it's a nice technique to have in your armamentarium because that incision doesn't violate the angiosome. It's within that one angiosome. It's not on a border between two. Great, yeah, and I think this was a paper that you put in. It's again just confirming that you do get a significant reduction in wound complication rate, and there are both case series and RCT that confirm.
That's great. Thank you, Lucky, for sharing the cases, some tips and tricks. So I was going to take a minute here, just whilst 4 of us are there, to see. Obviously, our practice has changed over the years, and you mentioned, Lucky, you've not done an open in about 10 years. Roland's presented a beautiful case. of an open, perfectly well healed. Alex, I'm sure, as a trauma surgeon, has a bit of a take on it as well. So should we spend a couple of minutes just to see what everybody's doing, and then we can go with your cases, Alex, after that. So I'm going to ask a question. Do you do full open reduction internal fixation using extended lateral approach for majority of your calcaneal fractures? Yes or no?
For me,
any of you?
For me, no. I haven't done an extended lateral like that for some time. That case that I presented was probably 6 or 7 years ago now. And I think, you know, I would still consider it. I've treated, my practice is probably a little different from Alex and Lucky because I don't work in a major trauma center. I've actually treated, I think, 3 medical colleagues within the trust, plus 1 or 2 nurses with these kind of injuries, and they've been isolated sports injuries from things like bouldering and climbing and so on. And they're just a slightly different patient cohort. These are very motivated professional people who will look after wounds and elevate strictly and have no comorbidities. And so I still think there's a role for it in these lower energy, more isolated injuries. But no, I mean, generally I've switched to the more invasive techniques.
Yeah. And I was looking at Alex's head going in the horizontal direction rather than vertical. So that is so I don't do. And like he's already said. So I think obviously Roland's making a point, and particularly it depends on your techniques that you've learned over the years as well, and where you are in the world, because we are global today. We're not just in the UK or US, and there will be places that people have to do open reduction internal fixation fully, and also the timing of surgery, etc. So Alex, Lucky, do you want to say anything? Because we got more than halfway through in our hour, and we got quite a couple of cases, nice cases to discuss.
Yeah, so can you hear me now? Can you hear me?
Can hear you, but a bit faint.
Yeah, I'll talk louder.
I can hear you. Yeah.
Good.
So go for your cases then, Alex. Thank you.
Yeah, so I'm Alex Trompeter. I work at a level 1 major trauma centre in London, and I'm not a foot and ankle fellowship trained surgeon. I'm a trauma surgeon, but I fix calcaneal fractures. And so a bit like Lucky was saying, the majority of my cases are high energy or associated with multi-polytrauma patients, or poor soft tissues, or a combination of all of the above. And so I've done a couple of extended laterals in the last 10 years. I think I've done 2, and I have a 50% complication rate. And that's a great way in anecdotal medicine to turn you off something pretty quickly. I do use the sinus tarsi approach in some cases. I think it's fantastic, especially if you ever have, for example, a combined talus and calc. It's a great approach, which is surprisingly not as uncommon as you think in high energy trauma. But I really like minimally invasive percutaneous surgery. So I thought I'd share a couple of cases, and we can go to the first case. This is a sort of typical one of my patients, and you've seen similar pictures already of the rotated posterior facet. It's a pretty large piece. This is actually virtually the whole facet itself. So unlike the last case where 50% of the joint stayed up and 50% was rotated, this is the whole thing. It's almost, it's transitioning between tongue and joint depression variant. It's sort of, it's not sure which one it is. And so this guy's got a suite of other injuries, and you know, his soft tissues aren't great, his physiologic status isn't great, and I don't think this needs a big extended approach. It just needs the subtalar joint reducing, and most of the rest of the calc will follow. So when I look at these, and I do a lot of minimally invasive surgery, I often tell my fellows or residents, like, the hard part of minimally invasive surgery is not the fixation, it's the minimally invasive reduction. That's the difficult bit of the operation. And we see so many cases of minimally invasive surgery where the fracture is still not reduced. And that's kind of the worst of all worlds. So the question is, how do you reduce these minimally invasively? And there are a couple of tricks and tips that I do, and I'm sure the others have some to add. And if we go to the next slide, it will show you. So unfortunately, it's jumped ahead a couple of slides here, but this is now pretty well reduced. What has happened from the first picture to this picture to allow us to get here? And there's a couple of wires. Actually, one is currently overlying the skin. It's not the whole way through the foot, but it's overlying for a trajectory. The first wires I do, what I tend to do is I do them in the lateral position. I spend some time just sort of stretching everything. So I hyperplantarflex the forefoot and the hind foot, and it's called almost like a Gizane maneuver. It's like you're trying to bend the foot back, and that helps bring the forefoot back to meet the depressed fragment, and you can help rotate the posterior fragment. And then I put a couple of wires in, usually 2, and they're the wires, typically 3.2, 3.5 wires for a 6.5 screw, and I'll put them into the rotated fragment following the facet, even if the facet is down, and then I'll lean on those wires. And one of the tips I have for you is to grab the wires as close to the skin as you can, rather than further away. So otherwise, if you grab them far away, the wire bends outside of the human. If you grab them near the skin, the wires will allow you to rotate the fragment. And typically, I do it on 2 wires. I rotate both, and I've still got the forefoot plant flex, and you'll see the facet rotate. Sometimes I would do it, then I relax, wait a minute, and then I go back and give it a bit more, and give it a bit more, and eventually the facet will come up. You can control varus and valgus, especially if you've got 2 wires there. 1 wire is not as strong as 2, and then what I typically do is I'll let go of the lateral wire, keeping the medial wire bent round, and then drive the lateral one on first. And that's the one that often has the longest trajectory down to the anterior process. So it gives you a bit more bite. This fracture pattern here didn't need to go into the anterior process. You can actually still see the fracture. The screws are almost perpendicular to it. So it's all about how you use the wires. So the wires are the ones for the screws. People get really anxious that that wire gets very bent and won't then allow the drill or the screw to pass it, but it bends outside of the bone. It doesn't bend inside the bone, so it's okay. So you can see here now, we've added a couple of perk screws. I've added a vertical screw. I've done that a couple of times. In my head, it sort of stops the piece sinking down again. I don't know if it truly does anything. It's quite fiddly to get 3 screws past each other in that area at 6.5. And I generally use, if I need to, only 1 partially threaded, but then fully threaded all the way to give me as much hold on real estate as possible. So that's kind of my standard reduction technique, if you like, for these sort of fractures. I don't know if the others have any comments on reduction maneuvers for minimally invasive.
Yeah, I think, Alex, you've described a lot of the techniques. The only thing that I've added is putting a little stab incision somewhere sort of down near the perineal tendons, and then putting a periosteal elevator in really low down, quite a way below the fracture, and trying to move that whole kind of block. So you're moving the posterior facet fragment, but with a large amount of cancellous bone. You want to lift it with as much bone as possible, so that you've got, as you say, you've got something to fix. So I've added that as an adjunct. I think Lucky described that transverse pin to control varus valgus, and I think the other thing that's really noticeable from all of our presentations, Lucky's as well, and you've just described it, is the use of fully threaded screws. I think we all use a lot of fully threaded screws for these cases, because we want to prevent, we're not trying to compress, we're actually trying to maintain or prop up a posterior facet. So yeah, those definitely chime with my experience.
Totally agree.
The only other thing I would say, yeah, and great tips and tricks there, both of you. The only other thing is I have a low threshold of putting a scope and just checking. I'm sure some do, some don't. There's no massive literature on it in terms of definitely makes a difference, but it does make a difference in my head to just see the articular surface a little bit better. But one of those things. We may have time to actually come to that in the end. Do you want to present your next one, Alex?
Okay.
Yeah,
I
go on.
use to scopes, so it's that's an easy decision for me. I just thought we ought to touch on open injuries and bad soft tissues, because the calc is unforgiving when there is bad soft tissue, as is most of the foot and ankle. Open fractures do occur, and historically they have a terrible outcome in calcaneal fractures. If they're open and then combined with an extended lateral, that seems to give the worst outcome of all, with a pretty high amputation rate reported in the literature. But we do get them, and the question is, what can we do? And this is absolutely, for me, the minimally invasive sort of game changer. You know, you can't really leave the facet here rotated. He is open. They're typically open medially more than laterally, although they do open laterally and plantar as well sometimes. So in this case, you see the next case, really just to sort of show, again on the next slide, the similar challenges. So we've got a really rotated facet. It's predominantly the whole facet. Again, this time the tuberosity is separate. And I've used very similar maneuvers, I think, with the open, exactly as Roland said. We've made a little window at the medial side to debride the wound. I've added in a little periosteal just to help me rotate that fragment, and then really just used a selection of screws to give me a kind of like a rafting, and sort of they're biting into that good quality subchondral bone right under the facet. That's the best bit of bone in the calc. That's why it's stayed as one. So that's probably the best real estate to get your screws into. And here you can see we've picked up the anterior process of the calc as well to give us that sort of long rafting screw that now sits underneath that piece that was rotated. So it gives us a sort of a really good armamentarium. These aren't easy to do percutaneously, and they take a bit of practice. And my advice as well is for people who are not used to this is to, and I did a AO fellowship with Rich Buckley, and we did loads of calcs, and every single one he had a bony calc or a plastic calc on the side in the theatre to look at and understand where your screws are going to go and what you're doing. You know, on the X-ray, you forget that the lateral column is much longer than the medial column when you're looking at it from a lateral X-ray. And so you've got to remember, only your lateral screws will be super long. And so there are things like that that take a bit of time to sort of get your head around, but it's a good technique.
Great, thank you.
And then just to finish, you know, the sort of really high end spectrum. This guy's polytrauma, many injuries, including a nasty distal tibial shaft, which is open. The skin's just about okay in the calc. We're doing the tibia, and he's getting a fix and flap on the tibia, and I'm kind of there. And if you look at the next slide, you'll see he's got another one of these sort of rotated sort of calc large fragments in amongst everything else, and that's a pretty flat bolus. So I don't really want to leave it. He's got a lot of other limb changing, limb threatening injuries. So what can we do that's minimalist, that at least is going to give him a reasonable function, or in the future, if we've got to do a subtalar fusion, a much easier subtalar fusion. And that all, therefore, I'm interested in is two things: putting the facet basically in the right place and putting the tuberosity in the right place without giving him infection. That gives you correct heel shape. He can wear normal footwear. And that seems to be the stuff that I think in these really high energy things we should be chasing. And so here again, you just see it, but you know, another couple of perk screws, all done minimally invasively, a pretty good reduction. Maybe a couple more degrees rotation would have been good, but not bad for the injury and the position we're in, given the sort of nature of polytrauma and what have you. So I'm not saying it's the only way. I'm saying it's a really powerful way. And it's a very, very soft tissue friendly way, but you need to know how to reduce these in order to be able to fix them percutaneously. Thank you.
Fantastic. That's great. Thanks, Alex, for one of those amazing, really nice cases. Thanks very much. So we talked about a little bit about the arthroscopy, and there is some emerging literature, not to the point of the sinus tarsi versus extended lateral. Is more on the lines of, are there any adjuncts to look at the joint surface, particularly when you are lifting the posterior facet up? Could you actually watch it happening in the right place? So, as I said, I do not for every case. I do have the scope on standby because I just like to do scopes. So one of those things. But if we look at it, the next one, please. So there is advantage to look at the fragment. You can wash out the joint, any debris, etc. And you can also quantify sometimes the amount of damage the joint surface has had. So you know even if it looks great on the X-ray, the chondral defect at the start is definitely going to lead to some subtalar changes subsequently. Next one, please. And much like what we discussed with Alex's cases and what Roland was saying, using a combination of techniques, you put them in the right place roughly and let them heal. One of the things I find difficult with percutaneous sometimes is the varus valgus alignment, getting it absolutely spot on, particularly if it's very comminuted fracture. You struggle, and I think it's important to get the axials absolutely spot on and noticing where the alignment is, because important to get the articular surface as good as we can with percutaneous, important to get heal roughly in the right place. But on the right, as you can see, you've had 3 or 4 stab incisions to do an arthroscopic percutaneous fixation, and the wound healing, touch wood, in my hands, and I'm sure others will echo my thoughts as well, isn't an issue anymore from Calcaneal side. Right, we've got a nice case from Lucky next, a bit of a salvage and smashed up, and then I think after that we just go for any Q&A or any discussion points. Thank you, Lucky.
Brilliant, thanks, Jit. Some great. I always love these things because I learn bits as much as everyone else. And so just before we move on, I wanted to say one of the things we probably don't use as much, which I've started doing more, is an AO distractor, which can really help. You can either put it medially or laterally. It can really help with that hindfoot varus and jacking out to have room to elevate bits. But this case is one that I'm sure Alex also sees quite a lot of. This is someone who was a young gentleman who tried to commit suicide, so jumped 7 floors, and as well as bilateral calcaneal fractures, he had spinal fractures, had spinopelvic dissociation with pelvic fractures, both femurs, 1 tibia. So this is a huge amount of injuries, but often, ironically, it's the feet that tend to be the problem in the long term and cause bother. So you can see here it's bilateral calcaneal fractures. When you look at the right side, which is probably the slightly worse side, you can see that the whole sort of subtalar joint, you can't really make out much of a joint at all. It looks like there's loads of pieces there. You can see that classical talus has flattened out, so it's dipped into the calcaneus. Not too dissimilar a picture on the other side. And if we just move on, Roland, thanks. The CT, so this is the CT of the right side, so you can see that there's very little that you can reconstruct here. But as Alex has pointed out, that doesn't mean there's not something you can do to make your life easier in the future when it comes to subtalar fusions. But key things to look at here, we've got a bit of a tuberosity fragment to work with, but there is a load of other things going on. And actually, if you see there's some air bubbles, so this was an open injury as well. If we move on, I think we should have some pictures of, oh yeah, okay, so again, big lateral wall blowout, and this calcaneus is essentially toast, right? It's really badly damaged. Next one. Other side was a bit better. You can see you got a bit more of a lateral sided posterior facet to play with, but again, if you look at your anterior process here, you can see there's a big split along it, and it's actually quite comminuted in some parts. So if you skip a couple forward, so again, just actually one back there, you can see that on that previous CT, what you could see is look, everything is completely gone underneath the fibula there, and it's completely subluxed out of the place. So the problem is that this guy's had 8 hours of spinal surgery, and you get an opportunity to go in at the end. And really, this goes back to Alex's point, which was that even though this is really badly damaged, just by trying to improve your height of your tuberosity, get your alignment a bit better, try and get your calcaneal length out, that can have a significant effect on the patient in the future. So you can see here, you can just see in between the two screw holes there's a shank pin line. So we got something into the tuberosity, we pulled it out, tried to restore length, tried to restore the inclination. That's all we did. There's no open incisions here. And as you can see, what we've done is fired 2 fully threaded screws into the talus, just to try and hold this alignment as best we can. And when I started doing this with the thought that we would have to go in and take all of these out. But as it happens, we've not really had to. I think, Roland, if you move on, you'll see the other side. Again, a similar sort of thing, trying just to restore the axial alignment. And this side, we probably didn't do such a great job of getting the length back. And if you move on, we've got some x-rays that were done at 12 months, I think, next. Brilliant, thanks. And you can see there that the left side, I think we've done a pretty good job of trying to restore everything. And you can see that that's going to be an easier subtalar fusion for us, because you're not going to need a big bone block here to try and restore the anatomy when you do your fusion. The right side, a bit less successful, I would say. Calcaneus is a bit short, but it's a really great technique when you've got a really smashed calcaneus and you haven't got a lot of time to do much with. Thanks very much. Back to Jeff.
I totally agree, and I just wanted to say one thing, because I've done a couple of late fusions where the patient has just been totally neglected, and we forget the tuberosity will continue to migrate north over the next few months. And doing a fusion where you've also got to do a distalizing tuberosity osteotomy, and then you've got an osteotomy site and a fusion site that you're all trying to get to unite in typically a usually polytrauma type patient who may be a smoker, isn't that healthy. All of those things conspire against you. This is minimally invasive and is just about putting the bone in the right place. It's no different to using a hindfoot nail for frail ankle fractures. We're just using what good bone we have to hold the bad bone in the right place.
Yeah, great case as well. Thanks, Lucky. Thanks, Alex, for sharing your thoughts as well. So, there's been a randomized control trial looking at primary fusion with fixation versus just fixation for these type of smashed up Sanders 4. And they couldn't show any particular difference in the outcomes, but these are injuries that they are going to be very difficult to make a decision on. Yes, we definitely must every time fuse it, or definitely must just get bits of bone in the place so that we can do a subsequent subtalar fusion. The only advantage that they've alluded to in this paper is that you're there. This is probably okay to just go ahead with fusion if it looks that smashed. But yeah, that's a good discussion point. So thanks, Roland, for the next slide. Thank you. So in summary, obviously, we know it's a very challenging injury to treat, and the cases have highlighted that. All of the cases we've seen have brought out some really good learning points. There are randomized control trials in this particular injury, and even they haven't been able to show a significant amount of difference between ORIF or non-ORIF. But on non-ORIF, the ORIF techniques were all pretty much full open reduction internal fixation in those previous randomized control trials. This bit of evidence that we've seen is moving towards MIS techniques, and it's being supported by all the systematic reviews and meta-analysis. Some of the factors that affect the outcome are age over 50, obesity, if you are heavy manual laborer, certainly workers' compensation in American studies, bilateral fractures, and if you do vasculopathy or anything like that. And if you're a man, unfortunately, or for a first are at a disadvantage if you break our calc. We're not going to do well. Next one, please. Okay, great. A big thank you to you all. Well, thank you to my panelists, first up. But before we have about 3 minutes. Yeah, so we've got 3 minutes, and we've got Selene online now. Hi, Selene.
Hey
Great
guys,
stuff.
fantastic job.
So we've got a couple of quick questions. Hi, thank you. We've got a couple of quick questions from Metwali. I think we can take that. How to control the sagittal rotation of the depressed fragment in sinus tarsi approach? Aki, do you want to take that one?
So what the sinus tarsi approach does is it gives you a great visualization of your subtalar joint. You can still use things like K-wires as joysticks to help with your rotation. And so that's usually my technique. I don't know what the others do, but I tend to put some wires in and use them as joysticks to correct the rotation. And the advantage about the sinus tarsi approach is you can be looking across your joint as you're doing that, and then you can get your read just at the angle of Cassagne, which is usually what I do. I don't know if anyone else has any other tricks.
Very similar. I think what people forget is that the sinus tarsi approach is giving you the approach to reduction should be the same through an open approach or the sinus tarsi through the ELA or the sinus tarsi. You're looking with the sinus tarsi at the main area of interest. The ELA gives you an awfully big view of the bit that you're perhaps less interested in, which is the sort of lateral wall and the tuberosity, and you struggle to see the joint. So all you're doing is you've moved your area of interest into the sort of central bit of your surgical field with the sinus tarsi. Reducing that fragment, I use the same techniques.
The only thing I would add is it is very easy to underestimate how far you have to elevate that fragment. You know, you think you've got a half decent reduction, and you can still actually be a centimeter or so off truly elevating that fragment and restoring that angle of Jeyaseelan. So you really have to work hard to to elevate and then maintain that elevation. K-wires are brilliant. You can sometimes sneak a laminar spreader in through the sinus tarsi approach and keep that up. You can use bone graft to maintain a temporary reduction until you then fix. There are various sort of adjuncts to reduction and maintaining that reduction before you go for your definitive fixation.
Awesome. Well, guys, thank you so much for helping to explain and bring insight to acute calcaneal fractures, because we already got the neglected ones.